What are the specifiers that we have in the field of addiction in DSM-5? First of all, we have some severity specifiers, right? Mild, 2 to 3 symptoms. Moderate, 4 to 5. Severe, 6 and more, right? We also have some specifiers regarding their status of treatment in terms of whether they are in early remission, sustained remission, or in a controlled environment. For example, they are in prison and they are not using, but it doesn't mean that they are in recovery, right? Do we have any specifier like what we have in MDD in terms of some clinical specifiers in the field of substance use disorder? Technically, we do not have any specifier in DSM-5 for addiction. But in reality, we know when we have a patient with substance use disorder, they do not come just with pure substance use disorder. They all have some really important clinical features around them that they inform the way that we prescribe medications, right? And these are what we call psychiatric comorbidities, co-occurring mental health disorders, dual disorders, whatever, terminology that you want to use. But they are technically acting as sort of specifiers around substance use disorder. And there is already an ongoing discussion about the next generation of DSM, whether we have enough evidence to bring some specific specifiers for substance use disorder because they inform the way that we prescribe medication. And this is how psychiatry works, right? So we treat the patient based on all those factors together, and these are the important things that we'll discuss today. So today we will have 2 presentations, fantastic group of people. Christian is already here, Narayan is going to join us, and we have Francisco and Marta. They are going to discuss about these sort of comorbidities, and we have detailed discussion about psychotic comorbidities and also mood, anxiety, and cognitive comorbidities. So we will have lots of fantastic discussion today around these sort of specifiers and how those things are informing the way that we are doing treatment. Does it make sense so far? Any questions so far? Okay, so let's just kind of further move forward with the case vignette. And then based on that, we can further discuss on what you are interested to learn. So we have Mr. Z, 46 years old, divorced man, businessman who is seeking treatment for his amphetamine use. Okay? Reports he drank heavily in high school and college, used cocaine in college, and at that period of time, he could concentrate much better, get a lot of things done without sleep, and feel normal with cocaine. He reports that he had many serious problems with cocaine in the past, but he currently only uses methamphetamine a few times a month, generally in the weekends. Does not currently report criteria for amphetamine use disorder, but he is still concerned that about his meth use. And he denies any opioid use or intravenous kind of drug use. Okay? Sounds like a real clinical case scenario that we can see in the clinic. Mr. Z reports that he has tried his 11-year-old son, Ritalin, on a couple of occasions and felt that he could concentrate much better and felt much less distractible. Mr. Z realized he should not using his son's prescription and decides to get evaluated for ADHD. He's currently put on ACE inhibitor and diuretics for hypertension. In the past, he has a history of doing reasonably well in high school, but when he got to college, he had problems with lack of structure in college. But he was doing still reasonably well, so he has never been assessed formally for ADHD. Okay, so that is the clinical case scenario that we have. And questions. How do you treat ADHD in Mr. Z? And how do you treat his amphetamine use? And how you address that amphetamine use? What are the suggestions? Anybody who likes to come to the mic and talk? No volunteer for now? I can pick people in the room. Please, just can use the mic as well. Please go ahead. Naltrexone, bupropion. That is your, and what is the kind of justification for that? Okay, good. So would you introduce yourself? Fantastic. So Dr. Mahmoud, just let us know about what are the other things that you want to know from Mr. Z? What are the other questions you want to ask? What are the other details that you want to have? Okay. Thank you, Dr. Mahmoud. Any other, what are the other things that you want to know from Mr. Z? Please, you can use the mic and just introduce yourself.
This is Mohammed Al-Noor, consultant psychiatrist, general adult psychiatrist. Yeah, I think also we have to consider if there's any depressive features. So you need to exclude depression and ADHD as Dr. Tam said. Yes, and it's probably needing adrenergic medication.
Okay.
So either partial agonist like pramiprazole or the train is, I think, it's going to be good choice for him.
Good. Good ideas. Thank you very much. Any other suggestions or any other details that you want to know? If I tell you that he also has anhedonia with low mood, how does that change your prescription? If I tell you that he has some passive suicidal ideations, how does that change your treatment strategy? If I tell you that he also has anxiety, how does that change your treatment? If I tell you that he has some anger outbursts and some impulsive actions and driving recklessly, how does that change your treatment? If I tell you that he has started to have some episodes of paranoia, how does that change your treatment strategy? If I tell you that he has a significant history of trauma, or he was a veteran and he has some bad nightmares, how does that change your treatment? If I tell you that he has problem with the sleep, how does that change your treatment? So thinking about those factors, even if he's already using alcohol significantly, and this is the presentation in initial place, but when you have the second session and third session, you realize that all those things are also in action, okay? So how these things are informing the way that we prescribe medications and how we can optimize that. So this is the way that we want to further discuss and move things forward.